slide, as the blood pressure goes up, your risk of death increases. But look at the chart from younger patients. So if a patient is younger, 30s, 40s, 50s, the risk of complication from hypertension is a lot more than somebody who is 70, 80 years old. So I'm very aggressive with my younger patients with hypertension.
Because they tend to have complications much earlier. Tend to have CKDs earlier, strokes earlier, tend to have heart failures earlier than the others. So you have to make sure the control is better in younger people. And as blood pressure increases, the risk also increases.
So hypertension or the blood pressure level is not the only problem the patient has. You need to look at other risk factors the patient has when you're evaluating. Okay, cholesterol issues, smoking, family history, very important. And then maybe they have some comorbidities, they may have had some heart issues, may have had kidney issues. So all these would then determine what will happen to the patient in the next 10 years. So you need to look at the patient in totality in evaluating these patients. So you can see the cardiovascular disease, by the time the patient has complications or stroke or kidney failure, a lot of things would have been going on. And so this needs to be evaluated along the way. Here, but look at this. A lot of things are contributing to what the complication the patient has. The patient diabetes, other comorbidities, and then they would then determine what happens to this patient with heart failure or not. So it's always important to echocardiogram and the right hypertensive heart disease. What does it mean to you as a doctor, as a pharmacist, as a nurse? So it's always important that left ventricular hypertrophy is not the only marker of hypertensive heart disease. It has several other things, diastolic dysfunction, systolic dysfunction. The aorta can get dilated because of chronic hypertension. Okay, if you do an unfolding aorta, these are all signs of hypertension. Left atrial dilatation, some may have endothelial dysfunction, coronary artery dysfunction, some may have atrial fibrillation. These are all signs of what we call hypertensive heart disease. And as I mentioned earlier on, hypertension with other comorbidities, other risk factors, then lead to the end organ damage. So in evaluating the patient, look at the risk factors that this patient has. Smoking, dyslipidemia, the blood sugar, may not be diabetes, but may be impaired. Okay? So look at all these, look at other subclinical end organ damage. Plus diabetes, does the patient have diabetes? And then look at established cardiovascular disease of this patient. So this is what will determine whether the patient will live in the next 5 years or survive up to the next 5 years or 10 years. And these are some of the basic investigations. I think the top one, patient doesn't have money as well. ECG, urine, dipstick, very important. Eye examination, kidney function is important. If the patient can afford echo and few other tests, can help evaluate these patients better. And then you can then put all these together and then risk profile this person. Last slide. So then with this investigation and evaluation and a history, then you can then look at the hypertension the patient has. So look at the right side here is where you have the blood pressure measurements. But if you look at the person probe, then you can stage the hypertension. So hypertension doesn't come alone, come with other problems. So is this a stage 1 hypertension where it's uncomplicated or complicated but asymptomatic, or the person has established disease? Then you can have hypertension with diabetes, with other risk factors, or hypertension with some subclinical entity. So when you look at this, then you come and look at the blood pressure. You can see that, yes, the person's blood pressure is 130 over 85. But if the person has other problems, like there's some kind of risk over there. But if you just look at the blood pressure reading, you miss important, aspect of the person's problem. Now, if the person has diabetes or has some kidney damage, then the risk is even higher. So that blood pressure is a lot more than what you think. So it's always important to have a complete evaluation of this patient, looking at hypertension with other risk factors, hypertension with some other established or subclinical end organ damage. So to conclude, hypertension is the main cause of death in sub-Saharan Africa, including Ghana. And most people die, you meet the person in a meeting like this, the following day, here the person is gone because of hypertension. And it's always important to confirm, make sure that you create the environment for the blood pressure to be checked properly. But the best way is for the person to have the blood pressure checked at home. And then evaluating, look at the person in totality, not just the blood pressure reading, check the sugar, check the cholesterol, check other things. And then it form the basis for management of these patients. And as was the theme for this year's May Measurement Month, we should detect blood pressure and measure it appropriately, control the blood pressure, which Dr. Jan will be talking about, so that we can all live longer. Thank you very much.
Thank you very much, Dr. Alfred Doku. The information may seem to be something quite basic and simple, but I always say that normally simple things are very serious. These are issues that one needs to really pay attention to. I would like to welcome our online viewers. We have a lot of people. Majority of them are GPs. Most of them are viewing this program on, I think, Facebook. We have others on other social media platforms. These are healthcare practitioners. They are not ordinary patients. Well, our second speaker is someone I have known for years. The husband is a very good friend of mine. These are people I have so much respect for because it appears as if they argue a lot in the house. Who is, better? The cardiothoracic surgeons believe that when it comes to cardiology, or even surgeons, believes that they are on top of everybody. Prof, don't be offended anyway. I hear them all the time. And then the internist and the cardiologist said that, come on, we know it all. And these are the arguments that happens in the house. Between the second speaker I will introduce, she's a consultant cardiologist at the National Thoracic Center, Cardiothoracic Center, Kolebu Teaching Hospital. She's also an adjunct lecturer at the School of Medicine, University of Health and Allied Sciences, UHAS, that is WHO. She's the person of Dr. Mrs. Desiree Desol Jan, and her topic is management of hypertensive heart disease. Ladies and gentlemen, please help me welcome our second speaker.
Okay, good afternoon, everyone. And thank you again. Thank you, Jonas, for his kind introduction. So, Dr. Doku has given us an introduction already on hypertension. And right now, I will talk about one of the cardiac complications of hypertension and the management of it. I think we know how to manage hypertension already. And so I just want us to talk a little bit about hypertensive heart disease. I will start with a case presentation. One patient that we met in the clinic. So let's meet Mr. Jonathan, a fool. He's a 56-year-old lawyer who was referred to see us on account of heart failure secondary to hypertensive heart disease. He has a history of hypertension for the past 10 years, and he came in complaining of easy fatigue, palpitations, pedal edema, and excisional dyspnea, which he said had been going on for the past 3 months. His drug history, he's on amlodipine 10 and Benadryl 2.5 daily, which he claims he doesn't really take every day. He said he actually started taking the medications after 2 years after being diagnosed because he didn't really believe that he was hypertensive. And then the medication, sometimes he doesn't take according to him because he forgets. He has family history of hypertension. Both parents are hypertensive. He has no history of smoking. He said he drinks beers weekends. According to him, not every weekend, and the most he would drink is 2 bottles. When we examined, he was a bit overweight. His vitals were essentially normal, except for his blood pressure, which was a bit elevated. So we did an average BP, and we got 158/94 millimeters of mercury. On physical examination, the positive findings was that he had bilateral pitting pedal edema up to the mid-shin, and there was some fine basal crepes when we auscultated the lungs. The rest of the examination was essentially fine. He was a little uncomfortable when he saw the blood pressure that we had obtained at the clinic, and so he informed us that his BPs are always well controlled at home. He pulled out a sheet of paper that his doctor had given him for recording his BPs at home, and his systolic BP ranged from 134 to 150 millimeters of mercury, with a diastolic ranging from 85 to 98 millimeters of mercury. So we did a quick average of the BPs that he had recorded, and the average home BP was 146/92 millimeters of mercury, which he claimed was normal. He said in comparison to what he was getting before, this is normal for the past 2 weeks. So we requested an ECG for him, and this was the ECG, sinus rhythm. As you can see, heart rate was about 75, and you see signs of left ventricular hypertrophy with the strain pattern, as you can see in V5 and V6. So we did an echo for Mr. Fool, and the echo showed a mildly dilated left atrium. He had concentric left ventricular hypertrophy. He had very good systolic function, an EF of 73, with no original wall motion abnormalities. And so our conclusion was hypertensive heart disease with grade 2 diastolic dysfunction. And this is a frequent report that we get for patients with hypertension who we send for echo. And so what really is hypertensive heart disease? And how do we manage that pathology? We know that hypertension is very prevalent in our part of the world. And if it is not well treated, we're going to get severe complications. And the cardiac complications are the main cause of morbidity and mortality in patients with high blood pressure. And it is also the main determinants when selecting a tailored antihypertensive therapy. Chronic blood pressure, it causes a lot of changes in the heart, both in the structure and the function of the heart. And these changes occur usually in the left ventricle, the coronary arteries, and in the left atrium. And as a result of those changes that take place in these parts of the heart, we have different cardiac diseases occur in patients with hypertensive heart disease. And the three main diseases that we see is heart failure, myocardial ischemia, and atrial fibrillation. So these three main cardiac complications of hypertension, they can take place separately or they can be combined at different degrees of severity and in various evolutive states. So what is the definition for hypertensive heart disease? As of today, there's no general consensus about the complete or comprehensive definition of hypertensive heart disease. The different cardiology societies and the different scientists, they can't agree on a consensus for what hypertensive heart disease is. And today it is just referred to as a constellation of changes in the three areas of the heart that I told you that is affected when patients have long-standing hypertension. So these changes in the left ventricle, the left atrium, and the coronary arteries, that result because of a chronic elevation of the BP, which increases the workload on the heart, inducing structural and functional changes. So in other words, we can say hypertensive heart disease is a direct and indirect sequelae of chronic high blood pressure, which induces hypertrophy in the left ventricle, which then progresses to heart failure. We have both diastolic heart failure and systolic heart failure. Rhythm abnormalities occur because we said the left atrium is affected, and the principal rhythm abnormality we have is atrial fibrillation, and then we have myocardial ischemia, which occurs because of the microvascular disease that occur when the coronary arteries are affected in patients who have long-standing hypertension. Now for the path of things, I'll just summarize because it's a little bit complex. So hypertensive heart disease, it induces myocardial remodeling and myocardial and vascular fibrosis. And what do we mean by myocardial remodeling? amlodipine, and we would add for these patients RAS blockers. Either we use the ACE inhibitors or we add ARBs to his treatment. And once he's out of failure, then we would add beta blockers to the treatment. You know, beta blockers is going to increase the diastolic time, and therefore that's going to encourage more left ventricular filling. We know these patients have very constrictive or restrictive, their left ventricle is not very compliant, and therefore we want to increase the diastolic time for these patients. So we want their heart rate to be on the lower side, maybe about less than 70. We want it, maybe even 60 beats per minute would be ideal for those patients. So the beta blockers are very good for these patients. It increases their diastolic time, increases feeling, and therefore give you a greater stroke volume, and therefore these patients will complain less of the easy fatigue that they complain of. Always very, very important to remember our target for our patients when we are treating them. We should not just, and we should let the patient know the target. Let them know where you want to get. What BP do we want to get for you? Most of the times in management of hypertension, we aim for a target of less than 140/90. But in patients with hypertensive heart disease, we need a lower BP target for these patients. And that's where Mr. Afuli's guidelines suggest that the blood pressure target should be actually between 120 to 130 millimeters of mercury. That's the systolic BP. And a diastolic BP should be between 70 to 80 millimeters of mercury. We don't want the blood pressure too low because we know that coronary filling takes place in diastole, so we need a good diastolic pressure. And at the same time, we don't want a very high systolic BP because we don't want any adaptive and detrimental changes to continue happening on our heart. And therefore, we need a systolic blood pressure around 120 to 130. And these are based on the guidelines. This is based on evidence medicine. This is based on studies that have shown this is the ideal BP that we need. And we have drugs from all the 5 classes, plus we have additional drugs that we can use to get our patients to the target. Also, we must never forget that these patients may have associated risk factors. And so we should not just forget, as Dr. Doku has already mentioned, that we are just treating a BP value. We have to remember the risk factors associated. All the patients are not the same. And some of those risk factors, we have to look for them, because if we don't carry out certain tests, we will never know if the patient is dyslipidemic or not. And the value that we get the patients, the LDL cholesterol level that we get, again, depends on the patient's risk. The higher the risk, the lower the LDL target you want. You use aspirin or clopidogrel, depending on if the patient has a history of maybe a cardiovascular disease. If the patient has a history of stroke, then you would want to use an antiplatelet for these patients. You want to maintain their uric acid level to the normal, because again, it is an additional risk factor for those patients. And those with diabetes, we want to maintain them at target, always at target. And so we want HbA1c less than 7 in the patients who are not elderly. And so in conclusion, next slide please. In conclusion, we can say that prolonged hypertension is the predominant risk factor for the development of hypertensive heart disease. Hypertension produces electrical, neurohormonal, and structural remodeling of the heart, which induces hypertensive heart disease. Treatment includes both pharmacological and non-pharmacological strategies. Antihypertensive medications like the RAS blockers, that's the ACE and the ARBs, the beta blockers, calcium channel blockers should be included in most of the patients who have hypertensive heart disease. Patients should always be treated to their target blood pressure. And once they have other cardiovascular risk factors, we need to control them also. Thank you very much for your attention.
Thank you very much. Is that all that you can do for her? I told you, consultant is speaking. Before we go for a short coffee break, short coffee break, because I know most of you have been working, you are tired, we need to get some coffee to, stimulate your system and to keep you going. We want to have a 5-10 minutes Q&A session. So please, if you have any question, our speakers are ready to address those questions. So please, if you have any question, just let me see you by hand. Any question? Any question, please? Any question? All right. Okay. Please.
The first one, okay, both actually go to Prof. J. So two things. In my experience, I realized that patients' home BP apparatus may not be working well. Because a few times, or a number of times, patients come in with BP checks that are very, disparity is quite wide. Patients don't know that these are machines and have to be serviced often. And so I think that that is something we should have at the back of our minds when we see patients, that sometimes you have to make sure that their BP apparatuses are working well. So that is something that I've noticed. The other thing is more of a question. So if you are seeing a patient who is, say, in the 40s, whose BPs are 90s, 60s, okay, those are the normal BPs. At what point will you decide that this patient needs support? Because I'm thinking that by the time BPs are 140s, 90s, that is a significant increase from what they had for the better part of their lives. So can you give me some more exposition on that? Thank you so much.
All right, thank you very much. So I think the first question is really very important. Before you encourage a patient to monitor blood pressure at home, at the index meeting, you can ask them to bring the machine so they can validate. They compare with what you get in the hospital. Even in the white coat, it will show the same. It will be higher in the hospital compared to what they get at home. At least, and the technique also. higher the risk of developing. And in a younger patient, we tend to look at the top one, the systolic. The younger patients tend to have the diastolic hypertension. So you could see a patient with blood pressure 132 over 110. Oh, BP, you're okay. No, it's not okay. The lower one is very high. So it needs, But to answer your question, the younger you are, the greater the chance of developing complication for the same blood pressure level. The youngest patient I lost to hypertension was 22 years old. When she developed hypertension at the age of 19, things accelerated faster. And you can have an 80-year-old with 160, be okay, living year after year. But the younger person, as I showed in the graph, has accelerated complications when they have hypertension. Thank you.
All right, thank you. Let me just throw this missile. A lot of experts are here, and I think that probably you need to look at it, and I strongly believe that it should change the way we think about hypertension. I think in 2006 or so, the writing group of the Hypertension Society of Cardiology was tasked to review the definition of hypertension. Now, that definition was never published. But when the JNC7 was being written, that is how come the pre-hypertension find its way in that document. Now, this is what they say. I would just to think about it, because since I understood the concept, it has changed my way of thinking about hypertension. Now, this is what they said. They said that hypertension is a progressive cardiovascular syndrome with many causes that result in both functional and structural changes to the heart and vascular system. For me, this is quite profound, because I think that if people could really understand the writing group proposal, it would change their mindset of what hypertension is, because most of it are not. Most of the things that you have discussed tonight fit into this definition, but nobody is really talking about. So people look at it in terms of discrete numbers, knowing that they will never look out for risk factors. And I think that is something we need to, being the expert, you need to look at it, and probably teaching students. I'm happy Dr. Mrs. Florence.
Yeah, so hypertension has moved from just figures. Okay, hypertension has a lot of factors contributing to it. And one key component is what we call neurohormonal changes. The question, why do hypertensive develop diabetes? Why do diabetics develop hypertension? There are a lot of neurohormonal changes. If you look at somebody whose blood pressure is 130 over 92, and you check the level of adrenaline in this person, really it's very, very high. If you check the level of insulin in this person, it may be very high. Renin-angiotensin aldosterone levels in this person may be high. So there's a lot going on. So I like the term hypertension as a syndrome. The syndrome means that it's a constellation of several factors giving rise to that hypertension. Okay? And hypertension causes damage, endothelial damage. The vascular bed is no longer the same. So what you see really is the tip of the iceberg. A lot is going on. So we need to look at hypertension differently. Somebody may come to you with hypertension of 148/100 and come with a stroke. Okay, it is because a lot is going on which is contributing to that stroke. And as a lady mentioned, if the person started from maybe 90 over 60, now it's gone to 140. The jump is so much, and a lot of injury to the vascular bed. So that's why the person is getting the complications. So let's look at hypertension in that context, rather than just the numbers you get from the patient.
Thank you very much. So we move out quickly. Oh, sorry, Dr. Mrs. John.
I just want to stress one point, because, hypertension sometimes is not, as Dr. Doku rightly said, it's not always defined as the values. We use the BP values of 140 over 90 to make it easier and to get general agreement among the doctors and all the professionals, the health professionals who are treating the patients. But really, if you have to look at all the complications associated with hypertension, we can define it as the blood pressure at which we will get more benefit in treating the patients than harm from not treating the patients. So for example, the diabetic patients whose blood pressure is 138, let's say, over 89, still needs to be treated. That blood pressure is less than 140 over 90, but it is too high for him. He's diabetic, possibly have some form of kidney disease. This BP is still too high for him. So it is not at the BP value that we know of 140/90, but because of the associated risk he has, this BP has to come down lower, and we should aim for a target for him less than 80 actually. So the risk factor determines what BP value you want for your patient.
Thank you very much. So please, we just take our coffee quickly and come. Oh, another question. You see.
Thank you very much, Dr.
Please,
Doku.
this should be probably last question.
Very brief.
Freeze the rest.
Very brief.
And then when we finish
The issue about the value can be discussed till even dawn.
Okay.
And I want to draw attention that the 140/90 is what has been agreed by some societies. The Americans are using 130/80 to diagnose hypertension. And as Dr. Jan rightly stated, it's based on where the benefits was found. They thought the benefit at 130/80 was still overwhelming, despite the risks that they found. The Europeans and other African and International Hypertension Society, we try to be conservative, and we look at the bigger picture. So with respect to the value, the 140/90 is not the absolute. But the benefit was overwhelming at 130/80, and we chose to stay with the ES. Thank you.
Thank you very much. Thank you. So please, let's grab our coffee, come in, because the second session is just awesome. Most of these medications, we don't have local studies, but we have a very robust trial with PreCardix. And our lead investigator is here to take us through what they found with this particular molecule. So, where, please? Okay, so please, we are moving here. Just quickly grab your coffee, pick something, and then if you want to empty your bladder, you quickly do that, and then you come back. Thank you very much. Just 3 minutes, 2-3 minutes, not more than that, please. 2-3 minutes.